bottle systems, okay? So the bottle systems were reusable bottles. They look like, I guess, big milk jugs or whatever. But he's going to show you that, and I guess it kind of shows how old we all are. Shows how old we are. So I'm going to go ahead and let you all hear him so he can kind of help you to understand, because when you look at this system, when we talk about this system, it's kind of hard to visualize what it looks like and how the chambers are set up. But when he describes it to you, it will help you to understand that you actually have a 3-system setup within this whole package here. So you have these areas over here where you're actually collecting the fluid. Then you have your water seal where your water is, and then you have your other seal over here, or your other chamber that actually regulates what's going on within the chamber. So you have these chambers all set up in this one little package. And he can describe it for you a little bit better. I was looking at some of the comments. I like to read comments more than anything else. And some of the people were pretty pleased with what he was saying. So let me see if I can get some volume on it. I think I'll be able to get volume.
Yeah, I'll turn it up on it.
Where do I turn it up?
It's just like a remote.
On the remote? Okay, let me see if that works then.
I don't know.
You started something now.
There it is.
Well, let's see if I can kind of go through it and talk it through if I can. So what he's showing here is actually how the system comes, see, from the patient, over there where it says from the patient, that's where the tubing is in the patient. So when the fluid comes down from the patient, the blood or whatever is coming from the patient, air is also going up into the other tube. So the air is being pushed up, and you know liquid fluid is going to be heavy, so it's going to go to the bottom. So that's what's happening here. It's showing where the fluid is going to the bottom. And then the air, where it comes, goes down and goes back up, and it pushes over into the other chamber, and therefore you have your third chamber where you're going to see your bubbling and all of that type of thing. So basically what he's showing you here is what the system is, and those were actually what we used back in the olden days. And then we came to realize that we could come up with something that would be a little bit better for us to use, and not those big old glass bottles. And somebody decided to create this. So you see now how he's tracing it out, where the air is going in and then out to suction. So that's how it works. That's the concept behind how this system works, okay? And like I said, you know, I wish I had been the one that came up with this idea and making all the money, but, you know, same concept. And there he's showing how he's circling it right there and showing you how the blood or liquid, the drainage is going down into the tube, air coming up, and it's traveling up and out through into the other bottle and over to wall suction, so to speak. So that's basically how that works. And since I can't get volume on it, I'm not going to continue to go through it and see on that part of it. But see how it goes through and shows you the same concept set up with this particular brand, because there's a lot of different brands, and he shows you in his video that same setup. So to answer that question, and I hope that it does, that gives you and shows you that within that containment, there are 3 sections in there, if that helps to kind of describe that and what's going on. Let's see. No, that's basically it. So that's all I wanted to run through and just kind of show you that and give you a visual of what the chest tube actually looks like. So now we'll go ahead and get started back on our lecture. And we got very little time. because of all of the issues that was going on with Candace. So let me be brief. So on the endotracheal tube, or your ET tube, okay. So on an endotracheal tube, the patient who needs mechanical ventilation, okay, must have an artificial airway. They must have an artificial airway. The most common type of airway is going to be, in short terms, your ET tube. Okay, so they're going to have an ET tube set up. Okay, and you can kind of see right here what it looks like. And then there's another little video that you can watch that's kind of going to give you some more information on what it looks like. So what the ET tube is going to do is it's going to keep the patient in a position so that they can keep a clear airway and be able to breathe sufficiently. Okay? What we want to do with this, of course, we are not going to be the ones that's going to insert this. An anesthesiologist, a nurse anesthetist, or a respiratory therapist usually performs this type of intubation. I know sometimes you've seen on TV, like some of the shows, the nursing shows, doctor shows, and all of that, how they'll have the patient secured up at the top. They'll kind of have them in what they call like a cradle type position up here, someone standing over the head, and then you've got someone else who is actually inserting the tube. They need to do that in order to keep the patient stabilized and try to get it in the correct place. Okay? Let's see. And here we're talking about the purpose of it. It's going to be an airway to keep a patent airway. And then we also have, see, like when you have that person that's actually putting it in, they're using that laryngoscope in order to get down into the patient's throat. And then actually once it's positioned, it's going to have a cuff that's going to be inflated in place. Now for us, there's going to be a couple of things that we need to understand and we need to do in order to care for these patients, okay? So what we're going to do is we are going to, during the intubation, the nurse is going to coordinate with the rescue response team, because usually this is going to be some type of emergency situation in which we need to have this tube placed, okay? So we're going to monitor the patient for changes in vital signs. This is very important. We need to monitor their vital signs. We need to watch and make sure that they are not having issues of hypoxia, okay, or hypoxemia. So all at the same time while these patients are being intubated, normally we're going to have another member of the team, whatever, doctors shooting orders out, and we're going to be getting labs at the same time that we're actually preparing this patient to get his airway stabilized, okay? So in order to verify placement, okay, in order to verify, immediately after the ET tube is placed, we're going to take these patients down in some kind of way if they can be transferred. If not, somebody from X-ray is gonna come up. And they're gonna check placement and make sure it's in the correct place. So they'll be getting a chest X-ray, okay? So we're gonna know that this is what's gonna happen. Okay, if breath sounds and chest wall movement are absent, no, why this thing keeps moving? Okay, let me go back. I'm sorry, y'all. I keep hitting this. Okay. So what's going to happen if breath sounds and chest wall movement are absent on the left side, and this is important, the tube may be in the right main stem bronchus. So that's important. I want y'all to know that, okay? Because just in case you have something, if you're asked that question, you need to know that if the chest wall movement is absent, it could be that it's not in the correct position, okay? So for y'all who've been in the emergency, in the rescue setting, and you've seen this happen, you know that this is what's going on with this patient, all right? So if the tube is in the stomach, what could you possibly see if the tube is in the stomach?
The abdomen area of the stomach?
Well, you could possibly see, what was it you said you possibly see maybe?
The abdomen?
At the abdomen is going to have air. You may see air in the abdomen. So therefore, they would probably need to be decompressed, right? So we're going to definitely go ahead and have them in a position, get a tube down so we can get some decompression. We need to get the air out of their stomach, okay? So we'll be looking at probably getting an order for an NG tube. Okay? All right. So the next thing that I wanted to point out to you, to make sure you understand that when an ET tube is placed, there's going to be one person who's going to be stabilizing the tube at the correct position, or placing that patient in a position so that the other person can apply the tube like it needs to be placed. Okay? So that's important for you to know. After the procedure is completed, verify and document the presence of bilateral and equal breath sounds. So for us as the nurse, our responsibility is to make sure that we are getting bilateral and equal breath sounds, okay? Another thing that we need to know, the priority nursing action when caring for an intubated patient is maintaining a patent airway. It's important to maintain a patent airway, okay? Assess tube placement. Check for cuff leak. Check to make sure there's no leaks around the cuff, okay? Check breath sounds. I'm not touching nothing, y'all. I promise I'm not touching anything. I don't know why it's moving like that. Okay. Check breath sounds. Indications of adequate gas exchange and oxygenation and chest wall movement. Okay? Those are going to be the things that the nurse is going to be looking at, okay? Another thing that the nurse needs to do when a patient has an ET tube is we need to prevent that patient from pulling and tugging on the tube. We have to prevent them from pulling and tugging on that tube. And they might do that. We don't want that tube to become dislodged, okay? We need to check the balloon pilot. The balloon pilot is going to be the little balloon that sits on the outside of the ET tube. If you look at the diagram in your book, you'll see the ET tube, and there's a diagram that shows a little bitty tube that hangs outside of the ET tube. That's called a pilot balloon. Okay? On the inside of the ET tube, there is another balloon, and that's the one that's going to be inflated. So it's up to us to make sure that we are checking that tube and making sure the integrity of the patient's throat is intact. And we'll talk about what we need to do for that, okay? Now, according to, and this is important, we need to check for the use of restraints. Because just like yesterday, when we talked about the patient that was constantly knocking over the chest tube drainage system or pulling out his chest tube, it is perfectly okay for us to have an order for soft restraints if we need to. However, to remain in compliance with J-code, we need to make sure that we are checking those restraints at every Q2 hours, however the facility orders us to check those restraints so that we are in compliance. Because, you know, a lot of times we don't want to use restraints, but in some instances, if we're using them in the best interest of the patient, it's better to do that because we are helping them and not causing any more problems with having to continue to insult the tracheal area, to continue to put tubes down. So we want to try to be as non-invasive or as lenient as we can as far as taking care of their skin integrity, okay? Complications of an ET tube. Now, there are some complications. Okay, the complications while it is in place or during extubation, when we're taking it out during extubation, okay, there is a risk for a pneumothorax. Okay, sometimes the tube can get obstructed. And another thing that's very important to note is bleeding. Bleeding could be an issue. Okay? Bleeding could be an issue. And infection. I mean, continuing to cause disruption to the skin, in the throat, that kind of thing. The patients are at risk for infection. Trauma and other problems can occur to the face, eyes, nasal, and paranasal areas. Why? Typically, when we're putting down these types of tubes, we're trying to establish an airway, right? So we're trying to establish an airway, and we may not be necessarily paying attention or looking at other areas of the body at that particular time and being careful in order to make sure that we're getting that patient an airway. So a lot of times when you come into an emergency situation and a patient is in distress and we need to get a tube down, we're not going to be let me, careful about this, careful about that. A lot of times people are running and rushing and doing things, and unintentionally some types of complications of this nature may happen. So you can look for those things. Just hopefully they don't happen, but you can look for them. Also, another complication may be that there could be some cardiovascular issues. You know, the patient could have some bleeding episodes. There could be hypotension related to that. So we want to look for that as well. And then again, neurologic or neuromuscular issues that could occur. Anytime we're doing a procedure of this nature, some nerves could be damaged. So we want to pay attention to that when we're working with a patient who has an ET tube. Oh, let's go back and look at this one where it says pressure necrosis. Is that up there? Yeah, pressure necrosis. That'll come. See where you see that little, on the tip down there, there's that little bulb that I was telling you. That's the bulb that's going to be inflated. And sometimes what happens is when that bulb is inflated too large, it can cause the tissue to die. So that's where you'll get that tissue necrosis from. That's what they're talking about there. Okay. Okay, so what we're going to do now is we're going to switch gears and we're going to run over here and talk a little bit about your CPAP, your non-invasive positive pressure ventilation. So I know that some of you probably know some people who have had to have a CPAP. or a BiPAP or something of that nature. The most important thing that I want you to know about the BiPAP, we'll start with that one. The BiPAP, typically it provides a non-invasive pressure support ventilation, and it's provided by a nasal mask. Usually they'll have a nasal mask on. Now this can be done when a patient is on a vent, mechanical ventilation, but a lot of times they'll have these when they're in the home too. So if you have a patient who has asthma or something like that, or if they have obstructive sleep apnea, the doctor may put them on a BiPAP or a CPAP, okay? So with this also, they'll have that nasal mask or a face mask. It is most often used for patients, like I said, with sleep apnea, but also may be used for patients with a respiratory muscle fatigue. In the instance, say for someone who's on ventilation and they cannot breathe effectively like they need to. Think about somebody who has COPD. They cannot breathe effectively like they need to. So the doctors may order this type of ventilation for them in order to cut down on the work of breathing that they have to do and allow the machine to help breathe for them. Okay, so that could be a reason for that. So what we want to do is also just make sure that the same thing, integrity, skin integrity, oral mucous membranes, because I've heard some people say, especially when they're on a CPAP, the CPAP, it blows that air back into the mouth and back down the throat. So we want to make sure that they're using humidification and doing good oral care with those machines. So, with the CPAP, what I need you to know on a CPAP, a continuous positive airway pressure, okay? It applies positive pressure throughout the entire respiratory cycle, okay? For spontaneous breathing patients. If they're spontaneously breathing, this machine is going to help them to breathe a little bit better, okay? If they are on sedating drugs, if they've been given, okay, or not at all, a patient who is receiving a CPAP, their respiratory effort is not suppressed. Okay, so if they have to have some type of opioid, usually opioids are going to suppress our respiratory system, right? So with a CPAP, it's going to help them to be able to breathe, and therefore it's going to take away that complication that may arise with someone who is taking opioids. So that's what we want you to know about that. So also, when caring for a patient who is on a ventilated patient, be concerned with the patient first. This is the first thing that we want you to know. If you hear alarms going off, anything like that, what I want you to know for sure is to check your patient first. That is the most important thing that you would do if you have a patient that is receiving some type of mechanical ventilation. Okay? Now, let's see, what else do I need you to know about a CPAP and a BiPAP? Okay, so let's say a CPAP and a BiPAP are used for after extubation. That's important to know. If you have a client on the unit, a lot of times they'll wean them down off the ventilator and they may put them on a CPAP or a BiPAP. So what I need you to know about that is that this is going to be used for them as well after they start to wean them off or once they are weaned off, okay? Once they are weaned off. As far as a BiPAP is concerned, a BiPAP, meaning two, a BiPAP is going to help them to breathe in and breathe out. So inspiratory assistance and expiratory assistance. That's why they call it a BiPAP. That's why they call it a BiPAP. Okay, and here it is right here. So it just kind of ties it all in. Okay? What a positive airway pressure does, what it does, what it helps with, what a CPAP does. And that's, basically the major thing that we would need to know about those two types of devices. Okay, so now we're going back to a tracheostomy. And we've had this before. We've covered our trach. We've covered it over and over again. The purpose of the tracheostomy can be temporary or it can be permanent. Some people think when they get a trach placed that it's going to be forever, but that's not necessarily the case. A trach can be permanent or it can be temporary. Okay? Okay, so the indications for a tracheostomy include acute airway obstruction. If there's an obstruction in the airway, they may need to have a trach placed. Because what happens is that trach, from that airway, it kind of goes past that airway where you swallow and all of that. It's going to go a little bit past that, and it's going to allow you to be able to get air in below the area where we would usually breathe in and out, like our nose and our mouth. Okay? Okay. Some of the reasons why someone might have to have a trach placed, because we just said the nose and those areas where we would normally have breathing, may be that there is some facial trauma. If there's facial trauma, they may need to have a trach, okay? All right? Maybe someone got burns. If they've gotten burned, they may need to have a trach placed. If there's going to be some type of head or neck surgery, the doctor may need to place a trach so that they'll be able to breathe better. Some of the other reasons that a trach may be used is if the patient is unconscious, if there is paralysis, or if there is an inability to wean the patient from a ventilator. So for us, our biggest thing and what we need to be aware of is that we need to be prepared to decannulize these patients. We need to always have it in the back of our mind, if they have a trach and it's a temporary trach, we need to prepare this patient to be ready to have that trach taken out. So we're going to keep that in the back of our minds, and that's what we're going to be thinking about. Our priority, the priority collaboration as well, is going to be that we want to keep in mind decreased gas exchange. Okay? This is due to the weak chest muscles. So that's going to be one of our nursing diagnoses, and one of our priorities is that there could possibly be decreased gas exchange with these patients. All right. With trach, we are looking at complications that could arise. Bleeding in small amounts, keep this in mind, bleeding in small amounts is expected. We expect them to bleed some. I mean, that's with any type of surgery. But if we see large amounts of bleeding, we need to be on the phone. We need to be letting the doctor know what's going on with these patients. So definitely understand that bleeding in any large amount is not an expected sign for these patients, okay? It's not an expected sign. Constant oozing is not something that you're going to see. Now, you know, when we did trach care, when we learned all about doing that, cleaning the trach and all of that, and I'm sure maybe some of y'all have seen some trachs since you've been out there in the field. There is going to be some secretion, but a copious amount of secretions and oozing from around the trach area, something else is going on. So we want to report that, okay? We also want to look at the possibility that these patients are at risk for pneumothorax. They're at risk for pneumothorax. We keep that in our minds during the time that the doctor's placing the trach. And in order to confirm that there's nothing wrong with the patient and that it's placed okay, we're going to get a chest x-ray. Chest x-ray for these patients, for respiratory patients, is our best friend. So we're going to check placement by getting a chest x-ray to make sure there's no probability that there could be a pneumothorax, okay? Subcutaneous emphysema. Subcutaneous emphysema could be a problem. We talked about that where you hear the crackling and all of that type of thing. Air can progress throughout the chest and into other cavities, into other tissues. It can even get into the face. It can even go around and get into the patient's face. So we want to inspect the patient, look at them. We want to palpate for air under the skin, okay? Palpate around a new trach. Check around that area. Make sure you don't feel anything that's unusual, okay? That's one of our nursing responsibilities. You know, in the book, I tell you what, that it's on page 540 in your book. That's going to show you how that cuff actually looks. We don't have, well, we have one. I got one picture here. See, this is where I was talking about, right here, that little area there. That thing is inflated in the neck area, and so there is always the possibility that there could be some kind of complication. This is that balloon. This is the one that I was talking about that sits on the outside. We need to also understand how much pressure we need to have on that cuff. And we're going to talk about some things that you want to listen for to understand what's normal and what's not normal in case you hear those things for testing purposes. And also just to know if you're going to be taking care of a patient that has one of these tubes, what you'll be listening for. In case you also get to go to the unit and work with one of the nurses, and she has one of these patients set up like this, and she's talking to you about things to look for and understand, you'll be, kind of aware of that, okay? So one of the things that we talked about too with these patients, and like on this picture, it kind of shows you how they are set up with the T-piece and everything, and to be able to get humidification. That's going to be important, because another complication that can happen is that they will end up with the secretions will become hard and crusty. So we don't want that to happen. So we want to give them some type of humidification. In addition to that, when it's set up with the T-piece, they can also get nebulizer treatments as well. So that's a thing to remember as far as your setup goes. All the elaborate stuff that's connected to them and everything is just a way of being able to humidify and give aerosol medications if need be. Okay. Let's see, is there anything else I want to talk about? Okay. So now we're going to move over here a little bit and talk about vents. Now vents, you'll get more information on vents when we get further along in level 4. Of course, we'll talk more about the PEEP and the pressures and all of that. But right now, what we really want to focus on as far as ventilators are concerned is knowing what we need to do when we are dealing with different alarms and things like that. Nothing heavy in this section. So that's basically what we're going to talk about there. Let me see if I can get this pulled up here for you. Ventilators. Okay, so if a patient is set up on a ventilator and the patient has, what are going to be some of the safety rules or safety issues that we need to consider if we have a patient on a ventilator? Keep in mind that all types of units fail. They can fail. So for us, we need to make sure that we are taking care of the safety part of it. So what can we do in order to handle that aspect of the patient who is on a ventilator? If it fails, what will we do?
Have an ambu bag?
Yes, absolutely. Make sure that you have, that's as good as it gets. Because what you need to be able to do is give them those breaths that they're going to need in order to get your team up and assess what's going on, that being respiratory, that being the emergency response team or whatever. Whenever we go in to check our patient, we want to make sure that they have that ambu bag at the bedside. And that is as straightforward as it gets. That's what you need to do. Very good. Okay, trying to see if I can find some other information. Like the pressure cycle, this is straightforward. All you need to know is that the pressure cycle, what it does, what the definition of it is. Volume cycle, same thing, just know the definition. Know that volume cycle, again, is the most commonly used. That's all you need to know there. And then time cycle. That one is not normally used, again, like it says, for adults. More than likely it will be for someone, a small child or something of that nature. So not too heavy right there on that information. And then here, the tidal volume, the rate. That's all of that stuff is going to be set by the respiratory therapist. The thing that we need to do is to make sure when we look at the settings on our ventilator, when we look at those settings, we need to make sure that they line up with what she set them at. Because sometimes the machine may get bumped and maybe a number is off or something like that. The only thing that our responsibility would be is to make sure that the respiratory therapist, what she set it at, what the orders say, is what it's saying on that machine. Okay? So that is as much as we need to do as far as the ventilator is concerned. I know I had some other stuff in here too that would kind of describe those to you, but I don't see it now, and that's as it would be. Okay, because I do want to talk to you a little bit about some other peak and all of that, because it kind of gives you a little bit better understanding of what we're talking about. Let's see. Okay, here we go. All right, let's go back to the controls. Okay, ventilator controls. So if we're going to be talking about tidal volume is the volume of air that the client receives with each breath. That's what your tidal volume is, okay? Same thing it says there. And with the rate, the number of ventilator breaths, to just say it another way, the number of ventilator breaths delivered per minute. So the ventilator is delivering the breath, okay? Is the breath per minute, but it's the ventilator breath per minute, okay? So that's what that means, okay? Fraction of inspired air. the oxygen concentration delivered to the patient or to the client, okay? And this is determined by the client's condition. That's the little extra add-on, okay? This number is determined by the client's condition and their ABGs. Whatever their ABGs show, whatever their condition is, this is going to determine how much of the oxygen they're going to receive, okay? Okay, so for the PIP. The PIP is the pressure needed by the ventilator. This is the pressure that is needed by the ventilator to deliver a set tidal volume at a given compliance. That's the reason why I say whenever you get a patient who is on a ventilator, make sure you know what those numbers are. Review it with your respiratory therapist, because all of this stuff, unless you have taken a course in order to be certified in dealing with ventilators, it's not going to be something that you're going to, be familiar with. If you decide to work in ICU, you will get your courses, you will get the training that you need in order to be able to understand what you need to do and how you need to care for your patient with your vent. Okay? So with your P, the P is positive pressure. It's extended during the expiratory phase. Okay, when they expire, when they breathe out, it's going to extend that time a little bit, because keep in mind, this patient's not breathing on their own. So this machine is going to slow it down and give it a little bit more time, a little bit more time for that breath to come out. So that's what's happening with the PEEP. Okay, and so next semester, when we start again, like I said, in level 4, you'll get more about the PEEP and how all of that works and how the patient responds to that and what the dials and knobs and all of those types of things mean. So we're not going to get that. We're not going to go into all of that right now. Okay. Enhancing gas exchange for us, we want to make sure that we take care of the patient, know their ABGs, know their trends, note the trends. That's important, because we need to know what the baseline is in order to understand if there is some change with the patient during the time that they are receiving mechanical ventilation. So note your trends, note what's going on throughout the therapy. Make sure you're able to see those trends, anything that's changing, so that when you call your doc, you can tell them that I see this going on or that going on, okay? Make sure you check your lung sounds. Whenever they are on a ventilator, you always want to check your lung sounds and make sure that the patient is not developing any complications. Now it says here to limit analgesics, and that's correct. We don't want to give them something that's going to depress their respirations, but we also say, keep in mind that when a patient has a CPAP or a BiPAP or something of that nature, those can help a patient doesn't have the work or the ability to be able to breathe like they need to. But at the same time, we're not going to be giving them a lot of opioids that's going to depress them even further, okay? We're also going to monitor their fluid balance, because these patients, they cannot get up, they cannot move around, so we need to make sure that we're not going to overload them, so we'll be monitoring that, okay? All of the complex diagnosis, all of that requires collaborative care. Again, we have our doctors, we have our respiratory therapists, we have these people on our team that we will utilize, especially when we work in an ICU unit or we're taking care of a patient on a vent. Not necessarily ICU, a lot of the LTACs have patients that are on ventilators as well. So we need to be aware of that if we decide that we want to go and work in an LTAC, okay? So for this one, enhancing gas exchange, you are the nurse caring for a client who is intubated and being ventilated. What should the nurse do if the ventilator is not working correctly or the client needs to go for a CT scan or MRI? Ambu bag. Keep that ambu bag in hand. That's your best friend. Okay? Certainly so. Or also, if they need to go for CT or if they need to go and have an MRI done, we need to be consulting with our respiratory therapy too. Because we don't want to disconnect any type of, bless you, any type of alarms, bells, any of that before we let the respiratory therapist know what's going on. Because she's probably going to want to follow them down too, okay? What are possible complications associated with a ventilator, okay? We need to look for barrel trauma. That you'll get a little bit more of when we move over into level 4 again. We need to consider infection, all of those types of things that could happen with these patients who are on a ventilator, okay? Cardiac function, we need to look at that. Barrel trauma, like I said, sometimes when the peak is increased too much, they're getting too much of a breath, they're getting too much oxygen, so we have to look at those things that could cause us more problems. Infection again, sepsis could be an issue. All of those things are complications that we deal with when we have a vent patient. What are we going to do for infection control? Well, we monitor their labs. We do all the things. We are hand washing. We have to make sure we're doing that. We're keeping them clean. Skin integrity is important. These patients may not be able to and will not be able to get up and go to the bathroom. So it's our responsibility to make sure we keep them clean, keep their skin clean. All of that, because usually on the unit, it's the nurse to the patient. You don't have the luxury a lot of times of having a tech on the floor with you. You are the sole provider for that patient, okay? Make sure we're taking care of the tubes. Check the tubes. Check for condensation. All of those things that need to be looked at. We talked about those already. Managing the cuff. Make sure that there is a certain amount in that cuff and not too much. Usually about 20 millimeters of mercury, somewhere around there. You want to make sure it's nothing above that. Providing oral care. Nothing is worse than a family member coming in and seeing their loved one with a crusty, nasty mouth. That is not good. We need to make sure that we care for them. We need to give them oral care. And that is just a part of that nursing 101 when you're in a one-on-one situation taking care of a patient in the unit, okay? Elevation of the head of the bed. Sometimes we can do that in order to help facilitate that breathing effort, especially if we're trying to wean them. You know, we need them to be able to get some breaths in. We need them to be able to take those deep breaths. And sometimes just to elevate the head of the bed, that's going to help. Be mindful of that and remember that too. Because in other instances, we ask that question, what can we do as the nurse in order to help facilitate a patient breathe better? Something as simple as the head of the bed, okay? Vent alarms. What do you do when you have an alarm going off? First thing you want to do is check the patient. Make sure the patient is okay. Then all of that other stuff that goes along with it. If it's a high pressure alarm going on, what are you going to look at? Are you going to check lines, make sure nothing's kinked, make sure everything is working properly, okay? If it's a low pressure alarm, what might be the problem, okay? Something as simple as the patient coughing or hiccups or something of that nature, okay? So your T-piece, we talked about the T-piece already being connected to the trach. If the T-piece is connected to the trach, it's basically there to help humidify, because those secretions can get hard and crusty. In addition to that, it is there to give medications. It can do that as well. So So it serves all of those purposes to help take care of your patient, okay? And that's all that is, that's all it's about. Okay, so remember, and we also talked about your Allen test and what we were gonna do for that and what we're gonna look for and if someone asks you the question about that Allen test and what it's all about and why you're doing it. So be able to respond to them if they are to ask you a question like that, that what it's going to do and why we do that. Now these last slides are just some FYI information for you when you're doing your studies to go over, and you can look at them and just kind of get familiar with what is happening here. Just to give you a little bit of a review on that. But what I want to do now is, if you have a sheet of paper, go ahead and take out a sheet of paper. Y'all go to lunch at 12, right? Or y'all
We go home.
We go to the house.
to the his house? Okay. So, and then we got another hour next week, and it'll be basically the same. So in order for me to cover everything that we talked about and all the little goodies that go along with that, the Allen test, again, is very important to understand what it's about, how we're gonna, what we're gonna talk to our patient about, what we might talk to our family about, why are we using the Allen test, along with drawing ABG. Who can draw ABG?
Respiratory therapist.
Okay, who else? The doctors, the respiratory therapists. We typically don't get ABGs. We can assist with getting ABGs. In addition to assisting with getting ABGs, as the nurse, there's something we can do, and that is assess. So when we are assessing, what would we look for? Keep in mind where they're getting this blood from, right? They're getting it out of an artery. So if that's the case, what would we look for as a nurse caring for a patient who just had ABGs drawn? Bleeding,
Cyanosis.
bruising, cyanosis, occlusion. Very good. That's one I didn't even think of myself. But bleeding, bruising, skin integrity. That's very important for these patients after they've had that test. So make sure that the nurse is monitoring that and that she's aware that those are some complications that could occur if she has that test done, okay? Let's skip over to your Venturi mask. Remember we talked about your Venturi mask and COPD? And what did we say about a Venturi mask? And it's most accurate, right, for delivering oxygen. So when you go back and do your studies, look at your mask, look at Venturi mask, look at your other mask, and make sure to understand which ones are going to be the most efficient in delivering oxygen to your patient, okay? Because that's kind of important to know if you have a patient who's having some problems. I don't want to give them oxygen through a nasal cannula if they need to get some oxygen and they need to get an accurate amount of oxygen, okay? So that's very important to remember. Did we talk about like things that could cause a patient to have a low pulse ox? Remember we talked about a couple of different things that could cause them to have a low pulse ox? You remember some of those? Fingernail polish? Yep. What was that? Yep, that's true. What about hypotension if they're hypotensive? Hypotension could be a problem, for sure. So that one is something that you might consider.
Depending on where you practice altitude.
Truly, that's right. We did talk about altitude, but yes, look at hypotension in relation to your pulse ox. and be aware of what you need to know as far as that's concerned. Now, since we covered lung cancer kind of early on, remember, I got kind of passionate about lung cancer and cancers because that was the area that, I loved a lot, working with the patients that has cancer, that's been diagnosed with cancer. We talked about dialogue, right? We talked about giving them the opportunity to express themselves. We want to encourage it, okay? So if they say something to us, if they talk to us and they make a statement of some sort that may require us to delve in a little bit deeper, we need to do that. We need to encourage them to talk to us and tell us what's going on, how they're feeling. We want them to express those feelings so that we can know how to care for them better. Maybe we need to consult social work. Maybe we need to have a psych consult put in. So those are some important things that we want to do for them when they're cancer patients. Now, if they're terminally ill, and they have cancer, it's painful. It can be very painful. I have had patients that have said that they didn't want to get dependent on pain medicine. So we have to educate them, right? We have to let them know that there is a low incidence, actually, of them becoming dependent on medications, and even so, it does not matter. It does not matter. It is important for us to make sure that we are taking care of their pain needs, right? So if they have cancer, especially in stage, they're going to hurt. And so we want to, and I know another one, this is a good one. Not only did the patient have issues, but the family member had an issue. They were in such denial that they did not feel like, or they did not believe that their family member was going to die, and therefore their main focus was on not wanting their loved one to become dependent on the pain medication, as opposed to them getting the medicine they need in order to have comfort. So that took a lot of education. So that is something that I really want you to understand when you have a patient who is a cancer patient who is possibly going to pass away, that we, talk to them and make sure that they understand that this pain medicine is not to get you through. It's to help you have comfort, okay? Let's see. So in my eyes, that's going to be a priority. When you have a patient who has COPD, there are a lot of different things that happen to them, a lot of things that happen to them. And some of those are, confusion. Some of those things might be that they cannot care for themselves. So we rely heavily and we talk heavily and we educate heavily our family members and our patients on the fact that we want them to let us know. They need to talk to us and let us know if they are having problems with activities of daily living, whatever they may be. So if they're having issues, we want to know it. If they are having problems with diet, we need to know it. Teaching them, we need to teach them about different types of maneuvers that's going to help them to be able to breathe better. We talked about pursed lip breathing. Did we talk about the huff cough? I don't think we did. We didn't talk about huff coughing. Huff coughing. Look it up. If you are not really understanding how to do that, look that up, because huff coughing might help them when they are having some issues. They're anxious. A lot of times they're very anxious. So we want to talk to them and find ways to teach them how to lower their anxiety level, because sometimes when they're anxious, that makes it worse, right? It makes their breathing worse. So we want to talk about that. I think that there is we all know how to help them with positioning, right? Positioning is important for any patient who has a lung disorder. Positioning is going to help open up the diaphragm. Positioning, what position? High fowlers, sitting them up. Anytime it's something that has to do with sitting them up or high fowlers or something like that, we know if it's a patient who has something going on that's respiratory, we want to definitely do that. That's one thing that we can do that's non-invasive that will possibly help them to be able to breathe better, okay? Now, if a patient gets medication, now we say it with cancer patients, it's okay to give them sedatives. We want them to have, not necessarily sedatives, but pain meds. We want them to have that for pain, but a lot of times we need to be careful when we have someone with a respiratory problem. We don't want to be careful, right, with opioids and sedation, because it's going to sedate them worse. If it sedates them worse, they might not be able to blow off CO2, right? So we want to be careful with that, and we want to watch that, because we may see some kind of trends when they have pain medicine. So if they have pain medication and they can't blow off CO2, it might be a good idea to look at lab work and know what respiratory alkalosis, respiratory acidosis, know what you're going to see. Know what you're going to see. If it's lower, if it's higher. Y'all know how these test questions work, right? Yeah. Instead of saying straightforward, it's like, what's happening with that patient? What you see this? Yeah, I see the numbers, but is it up? Is it down? What am I gonna do? What am I gonna do about it? What am I gonna see? So that's how it works. Now, I didn't forget about the medications. I didn't forget. Because I made sure I had them so you get something on monoclonal antibodies. Monoclonal antibodies. Monoclonal antibodies. Monoclonal antibodies. Know what you need to be teaching your patient about this particular medication. I think this one has a black box warning on it too. It does. If patient starts, a lot of times we talk about every medication, diarrhea, constipation. They all have it, right? In some instances, sometimes when you have maybe constipation or diarrhea, it could be the result of a medication causing you to have some type of condition. So with these types of medications, with monoclonal antibodies, if you have some type of diarrhea or something of that nature, it could be the sign of something else. So tell me what it is when you take a test. An intubated patient, an intubated client should not be able to make sounds, okay? If that patient is intubated, you shouldn't be able to hear any sounds because you got a bulb in place, and that bulb is keeping them from making any sounds. So if you hear some sound, if you hear some squeaking, if you hear something going on with that ain't normal.
Something wrong.
Something's wrong. Know what's wrong. Know what's going on. What are you gonna check? Huh?
Do you need like noise from the ET tube or the first
Like
like
if
the
there's a
pump?
leak?
Like it could be a leak. Yeah, like from the tube, from the client. You may hear some squeaky, or you may hear something from the tube, some type of noise coming around the tube. Like it may not be inflated to where it needs to be inflated, you know? So what might you do? What could you do? You know, what would be a nursing priority? How would you handle that? You wanna make sure it's right. You wanna fix it. So yeah, look at that. Look at that type of question. Y'all ready to go? You want me to keep going?
No, keep going. No.
We're talking, I wanna make sure that I'll give you some things to think about as you study. So you'll know where to focus your study.
Thank you.
The things that are most important that I feel like you need to focus on. Okay, chest tubes. We talked about chest tubes, I think we did. What's the care? How do we care for a chest tube? All of those little intricate details that we talked about that chest tube, and it should be second nature. Look at the 3 chambers. Look at what's going on with the bubbling. Look at what's going on with the titling. Don't be tripped up if it tells you, if the question says something about the bubbling is constant. We know that there can be bubbling, right?
Mm-hmm.
There can be bubbling at times, but don't trip. Know what you need to know about what's normal and what's not normal on your chest tube. Know how to place that chest tube. When I said place it on the floor, we didn't really get off into lines going here for air in the chest or around the lung and blood. That's not. You'll get that when you get out there. You got this tube here. There's air. You got this one here. We're trying to get off blood. I think it shows a pretty good diagram in the book. But what we do want to look at is we want to look at what if that patient pulls it out? What are we gonna do? What if it comes? We're gonna pray. We're gonna watch and we're gonna pray. We're gonna stuff it, or we're gonna stuff that thing with some Curl-X. We're gonna stuff that hole with some Curl-X. I don't want to stuff the hole with Curl-X, do I?
Was it the dry box?
What if you have an issue with the, well, hi. What if the collection chamber was to come dislodged? What would you do in that instance? How would you care for that patient in that instance? You know, it's important to know all of those things, what the care is and what's going to be our first response in order to take care of such issues. Okay? So, with a pneumonectomy, what can we do? We know that the lung is gone, but we still want to do the same things that we do when the client has both, right? We still, right? We want to care for them the same way we would a patient who's just had fresh surgery. What do we normally do for a patient who's come back fresh surgery? We use a spirometer. We teach them to cough, deep breathe, all of those things that go along with that, right? We want to teach them to do those things. That is quite appropriate. Okay? It's very appropriate to do that. Understand that there can be complications with chest tubes. Okay? Understand that in those complications, there are certain conditions that may be seen. If you see those conditions, what assessment would you see in relation to those conditions? Here's what I'm saying. You got a chest tube. Chest tube has complications that goes along with it. What are you going to see from that complication? Maybe, like we talked about the hemothorax and the pneumothorax and all of those different things like that. So if you have a complication like that, what are you going to see with that complication? Okay? All of this because of a chest tube. Okay, chest tube. Look at the, it's my responsibility to make sure I know that what my drainage looks like in my tube, right? I need to know what that drainage looks like. And if that drainage changes, then I need to be on the phone. Particularly if that drainage is like bright red blood or something like that. I need to know it. I need to make sure that I understand. Take care. Have a good day. So yeah, particularly that. If my drainage changes, if it cuts down, if it's not like, say for instance, if I got 500 mils out this hour or 2 or 3 hours ago, bless you, then if I only got 10 or 15 over here, then something may be wrong. So I might want to look at that. And also with procedure, yeah, just came to me. Like if a patient has a thoracentesis, what are some complications that could happen with a thoracentesis? I don't think we talked about thoracentesis. We did? Okay, so what are some of the complications? That might have been when Ms. Clemens was in here and I totally lost my mind.
Good puncture.
Yeah.
Thoracentesis complication.
Yeah, so very good. So look at that and what complications, the hemothorax, pneumothoraxes, all of those different thoraxes, and you know how do we handle them? How do we talk to the patient? What do we do for them?
Can you call the nurse?
Let me give you one more. Okay, I got a good one. What if I have a patient that comes in who has had blunt force trauma, and my doc says that they can go on? Okay, thank you. Y'all have a good weekend.